Thank you, Dr. Sunita, for inviting me to this important symposium on diabetic retinopathy, which is of primary interest for me. I have no financial disclosure to make, and it may sound like I'm promoting some of the cameras here, but no, I have no financial interest in any of these. Things have changed, especially in the recent past. We've had a very exciting time with the new cameras, new instruments to look into the retina. Earlier, it was a domain of the anterior segment surgeons, and very little attention was paid to the posterior segment. But with all these newer imaging modalities that have come in, I think things are changing. So I'm just going to touch briefly on few of those that are there and are yet to come. Imaging, of course, the conventional method is the color fundus photography, fundus fluorescein angiography, and in the recent times, the OCT. OCT has evolved with time, from the time domain OCTs to today's swept source OCT. You're seeing it's really surprising to see that we are able to see at the level of every single layer. We talk about 10 layers of the retinal structure, but then we were never able to visualize them. Today, we are able to see them layer by layer and identify the changes that are happening. With the OCT, things totally changed. How you were looking at the macular edema, the ETDRS fundus pictures were becoming obsolete with all the clinical trials using the OCT as a standard to measure how treatment is being evaluated. So the diabetic macular edema or a vitreomacular traction, which earlier was being treated as just diabetic macular edema, today showed that it needs a surgical intervention. And of course the tractional retinal detachment with different layers being pulled out with intraoperative OCTs, where you're able to know whether you're pulling on the membrane or on the retina is today very much possible. With this OCT, which is all of you are used to, the NFAS visualization came in, where it is based on the software reconstruction of the OCT images, where you're able to see the retinal layers in the coronal plane, where you're able to see how at each layer the structure is maintained, and subsequently the OCTA, that is the optic coherence tomography angiography, came in, and this changed a lot of things for us. From even when the OCT was there, fluorescein angiography was taking a back seat, but with the OCTA, it is really, in many places, it is very little fluorescein is indicated in many of the conditions. So the OCT, it scans the patient's retina with multiple individual A scans, which is compiled into a B scan to provide a cross-sectional structural information of the vessels in various layers. And with FFA, you were able to identify the microaneurysms by the leak, and with the OCT, the OCTA, you were able to identify where these were present, which layer, is it in the deep capillary plexus or the superficial capillary plexus, were all possible with the use of the OCTA. I was seeing that there were more chances of, the microorganisms are present more in the deep capillary plexus than in the superficial capillary plexus. With the identifying the NVA in this structure, where it's very, very subtle, you have to actually do only a fluorescein angiography to identify this NVE, whereas in the OCTA, you are able to look carefully. You will be able to see these structure, the new vessel membrane, and you actually see the extent of the membrane which gets hidden in the OCTA. Here you will be able to see the coiled new vessel structure. Even if you want to treat on this, you'll be able to see them. It was seen in the studies that the microaneurysm detection rate is still in OCTA was lower than the fluorescein angiography, but the areas of CNP and all this were detected much easier with OCTA. So I won't go to this. Then came the swept source OCT. This made a different, it was like seeing a different picture altogether. Now you were able to see the vitreous, the choroid, any changes that happening. With that advent of the development of this, when you were able to image the choroid, things changed. You were talking about pachychoroid, you were talking about the different conditions that are affecting, the CSR, how you were able to find the spectrum of this disease in PCV and various other conditions, even in diabetic retinopathy, how the choroidal changes were being studied. And this made a whole new change with these web source OCTs. And I just want to touch on this PLEX Elite, which is made by ZEISS. This is yet to be in the market, but it's more of a research tool at this point of time, being used in select centers. It's a web source OCT. It can give an ultra wide 12x12 single shot. It has a very fast image capture time, so even patient blinking or moving causes very little problem to the imaging in these structures. But what is very important to see is how the area is, you're able to see the area, the 12x12, with so much of clarity. And with the Plexielite, you could actually predefine the standard slabs, that is at which layer you want to cut, and see how the cells are structured either in the deep capillary plexus or in the choriocapillaries. You could make out all the differences. As you can see how the clarity of these blood vessels are in the superficial capillary plexus, that's in the optic nerve head. The other very interesting is the montage, which can combine the multiple 12x12 to get a 70-degree field of view of the fundus with such a beautiful, especially in these capillary plexus. If you had just taken a simple central view, you hardly get anything. You would think it's normal, but with this, you're able to detect the peripheral capillary non-perfusion area. And the high resolution of these images are just phenomenal to find out the vitreous interface and also those membranes that are pulling on the retina, or the retinal interface with the vitreous. Then came the multimodal imaging. Of course, it is there with using the different techniques, how you are able to arrive at this more useful in conditions like age-related macular degeneration or PCV. But of course, it is combining these modes. It is important that they are mutually registered to make a meaningful decision on this or interpretation of these images. Then came the ultra-wide field fundus photography. Of course, this has changed how we are seeing the fundus with the Optos, and the two devices that are there in the market as the Optos and the ZEISS Clarus, which again shows, all of you have seen these images where in the peripheral new vessels or peripheral lesions would be missed if you're just looking at the central images of the ETDRS photos. You're likely to see, and today this is becoming much easier for seeing the fundus with a very good almost 200-degree view of the peripheral fundus in these cases. In a case like this, especially the Clarus, which is a true color image, where you don't see any changes in the retina, which appears normal, but when you zoom it in, it doesn't lose any resolution, and you'll be able to find out that there are some hemorrhages or microaneurysms located in this. So zooming in actually helps, and you're able to identify those minute details that you may be missing. So there is an increased identification of diabetic retinopathy in these, and the increased identification of vision-threatening diabetic retinopathy in the different studies when you are comparing with these ultra-wide field fundus photography. Of course, this came the ultra-wide field fluorescein angiography, which showed there was a 3.9 times more non-perfused areas detected when you were doing this wide field, and there was 10% more retinal pathology was seen in these cases. I'll just mention about these adaptive optics. It's in-house visualization at the cellular level. You will be able to see the photoreceptors and the different irregularities that happens in diabetic retinopathy is being studied using adaptive optics, but still it's a research tool. Functional optical coherence tomography has been there for some time, but it's still some interests are being shown. It's still again an evolving field where we will be able to see many changes or developments in the near future. FLIO, or the Fluorescence Lifetime Imaging Ophthalmoscopy of the Macular Pigment, which describes the different patterns of macular pigment in different diseases. Right now they're studying more in age-related macular degeneration. Very few equipments are there or instruments are there in the market, in the world today, which is again still experimental tool to bring in. But what is important is that this is a very, very exciting period. You see a lot of new imaging devices that are coming in, which will help us to study at the cellular level clinically with non-invasive methods. And as Rajiv pointed out, the role of AI is being studied in interpreting these OCT images, or those subtle changes that the human eye can miss would be picked up using AI over time. So we are in that exciting period. We will have a lot of more devices and algorithms that will be coming in future for us to help the patients much better. Thank you. Thank you again.
Thank you, sir.